And just to review, as we talk about spinal cord injury, and including traumatic and non-traumatic causes in cauda equina as well. And as you know, many different aspects of spinal cord injury, whether it's congenital due to illness, injury, or iatrogenic, and hopefully not too many iatrogenic spinal cord injuries. The classifications that typically are used are the international standards for neurologic classification of spinal cord injury, as well as the ASIA scale, the American Spinal Injury Association. And we're not going to go into too much detail about the difference within those. Spinal cord injury, though, is a significant problem, not just around the world, but also specifically here in Saudi Arabia with recorded high rates through the Ministry of Health. And the slight difference between Saudi Arabia and the United States, while we do have a lot of road accidents also in the United States, we have a higher population of gunshot wounds as cause of spinal cord injury as well. And the rates in Saudi Arabia range between 38 and 63 per million in population, which is about, at the upper end, about 1.5 times the rates in the United States, which are about 40 per million. And one of the questions, though, is why the discrepancy? Which is it? Is it 38, which is closer to the United States rate, or 63? And it's probably related to the differences in the studies and variations in the definition of what's considered spinal cord injury, the inclusion criteria, classifications, geographical and cultural variations in different parts of the country, and both pre-hospital and hospital treatments that are available in different areas. Specifically for pain, about 1/2 to 2/3 of the population with spinal cord injury do have pain. Again, there's a wide range. Which is it? Is it half the population or more like 2/3? And again, because of the large variation reported in prevalence that does exist, a lot related to the definition of pain, whether or not the studies that looked at the patient population with spinal cord injury and pain was actually a study specifically addressing pain or something different, and use of retrospective data, going back into databases and mining for data, the timing post-injury of when the study was done, and whether or not it was a study specifically looking at depression and the rates of depression within the pain population of spinal cord injury. And along that point, and I'll touch on a little bit later as well when we talk about some of the medications, there's some conflicting evidence now of how much depression and pain are related specifically within the spinal cord injury. It may not be as high as we initially had thought. Although we heard a lot yesterday about some of the aspects of some of the psychological aspects related to pain. So the International Spinal Cord Injury Pain Classification came out with an update in 2012 published in the Spinal Cord, again talking about pain and the classification and talking about tier 1 of the pain type, which could be nociceptive pain, neuropathic pain, or some other or unknown pains. Tier 2 was to subset each of those, so nociceptive pain could be subclassified into musculoskeletal or visceral pain, which is not uncommon in the spinal cord injury population, or other nociceptive pain. And a big classification of neuropathic pain, which could be related to the spinal cord injury, could be at that specific level of spinal cord injury or below level spinal cord injury, or other unrelated neuropathic pain. And tier 3 looked at really a specific primary source of pain, if it was possible to identify it. And many different aspects. It could be spasm-related pain, or other overload that could cause musculoskeletal conditions, visceral pain being caused by constipation or other internal organ symptoms. Other nociceptive pain could come from pressure ulcer, or again musculoskeletal causes like nerve compression and carpal tunnel syndrome. And then neuropathic pain, whether that was a specific lesion in the cauda equina or a syrinx development, other spinal cord lesions, or post-thoracotomy pain related to a nerve injury from a surgical intervention for the condition. So specifically, I want to talk about neuropathic pain, and typically the diagnosis is clinical with a pain history, and it's important to take an accurate pain history to ask about the onset, the description of pain, the pain course, whether there's any variations in pain related to timing during the day or other activities, and any other associated symptoms. And in that end, getting the history and accurate history verbally, and using pain charts and body charts for how the patient would, where the pain is located. Diagnostic testing, and I have listed here things like MRI and CT scan and electrodiagnostic testing and EMGs, really are not to confirm whether or not somebody has neuropathic pain, but really to make sure they don't have something else as the cause of their symptom. Other supportive criteria, talking about the onset of pain within a year. Typically, it's not movement-related or musculoskeletal in nature. The descriptors, whether they're described as hot, burning, and tingling, that may be a help. And whether or not somebody has allodynia or hyperalgesia as part of their pain complex. Mechanism is not really well understood. There seems to be a similar prevalence in neuropathic pain in the spinal cord injured population as there is to those with a stroke and CVA, and probably some issues related to spinothalamic dissociation and sensory loss. Neuroplasticity that occurs in the central nervous system, both in stroke and spinal cord injury, actually may end up being one of the issues that can have negative consequences with relation to development of neuropathic pain and then sensitization issues, whether it's cellular change being responsible and non-painful. So this adaptation of the neuropathic grading system is to look at their pain, if the history, if they have a spinal cord injury and they have pain distribution at or below the level, confirmatory tests of negative or positive sensory signs, diagnostic tests confirming the spinal cord injury, other causes of pain excluded. If they have two of those, it's probably SCI neuropathic pain. If they have all of those, it's definite SCI neuropathic pain. Sensitization, again, is a common thing with hypersensitivity causing mechanical allodynia. There can be a summation of pain so that typically even a small painful stimulus can be perceived as much higher pain. And it typically then precedes, the neuropathic pain and central sensitization precedes the development of pain that occurs below the level of spinal cord injury. And a lot of different things. There's excess glutamate, NMDA, and other receptors, sodium and calcium channels, astrocyte and myoglial activation, inflammatory mediators and cytokines, imbalance between the descending interneurons, GABA loss, and again, do all those things with neuroplasticity inhibit or limit some of the treatment options. Just to review on musculoskeletal pain in the upper extremity, especially for patients in wheelchairs, shoulder pathology, elbow, wrist, hand, issues related to a variety of different musculoskeletal complications, and even in the lower extremity for patients that have incomplete injuries or utilizing some of the upright technology, may have hip issues, knee, foot and ankle musculoskeletal problems, and again, identifying the primary source of pain is important in this population as well. So what are the goals of the medications for pain? Obviously to improve pain and function, to avoid adverse effects. For the patient, we want to make sure they have limited side effects, decreased dependency or addiction. And from a public health perspective, all those things are important as well. And again, the physician prescriber wants to make sure they're not creating any additional problems. So a lot of different choices for pain in general and for pain after spinal cord injury listed here. And so we'll review some of these. One consideration, though, in the American Geriatric Society in 2015 updated their criteria for potential inappropriate use of medication in older adults. So for patients who had a previous spinal cord injury and now are older, or an older adult with a new spinal cord injury, it's important to consider those. Acetaminophen in general for pain, most of the studies look at hip and knee arthritis, and again, the spinal cord injured population may have those as symptoms. However, the studies provide questionable benefit. There's little to no efficacy, and it's described by Enos in 2016 as having dubious clinical relevance. And there's really no studies that have looked at the use of acetaminophen for chronic back pain or pain in the chronic spinal cord injured population. Comparing acetaminophen and NSAIDs, whether or not there's comparable efficacy or fewer side effects is questionable. And the difficulty is that it really depends on what you're looking for. When we look at back pain or even the spinal cord injured pain population, there's very few studies that look at those. So again, small effect on pain reduction when we look at NSAIDs, and little to no effect on the role and disability questionnaire. And this was a combination, a look at 4 different studies in a meta-analysis in 2017. Again, the difficulty with the older population and geriatric Spears criteria is that there is a risk of serious GI effect. and especially in the newly injured spinal cord injury population and the post-traumatic patient who is already at risk for serious GI bleed. Putting on NSAIDs right in the beginning of that may lead to further complications as well. Skeletal muscle relaxants are used commonly, but the question is whether or not they have direct muscle activity. Are they tricyclic in nature? What are the metabolites? So for example, one of the medications that has been used in the past of Soma has an active metabolite that's an anti-anxiety medication. And it really comes down to the definition of are you treating spasm or spasticity, and those are very different, with spasticity being the rate-dependent increase in tone. And that's just a drawing really of what cyclobenzaprine or Flexeril is and used as a muscle relaxant, but in reality is very similar to the other tricyclic antidepressant. So are they helpful though? Are antidepressants helpful for pain? None of these have really looked specifically at SCI, but that the tricyclics and the serotonin-specific reuptake inhibitors have no effect on pain, although duloxetine does have a small effect on pain related to generalized pain conditions and a small effect on function based on 3 randomized trials. Again, in the geriatric population, looking at anticholinergic and other side effects is very important. And so there's a lot of medications to avoid, including Soma, tricyclics, and the other skeletal muscle medications recommended to avoid based on side effects and essentially lack of efficacy. And again, specifically in the spinal cord injury population, making sure that you're not adding additional problems to them, especially with the anticholinergic and bowel effects for somebody, especially with an incomplete injury that may have worsening urinary retention due to these medications as well. How about pregabalin? In the general pain population, it doesn't seem to have much effect on pain or Oswestry disability or Rowland disability questionnaire based on these 2 studies within the last decade. But specifically for spinal cord injury, these studies didn't look at that specifically, so we'll get to that in just a minute. Opioids, really compared with placebo or other treatments for chronic low back pain, a Cochrane review in 2014 did find that there was a short-term efficacy on the use of opioids, but again, especially in the geriatric population, limited recommendation because of risk of fall. And again, in the spinal cord injury population, and the risks related to opioids may outweigh their benefits. So in the United States, the Center for Disease Control developed guidelines in 2016. And again, there were really no studies or no evidence and few randomized controlled trials or systematic reviews specific to spine conditions and none for the spinal cord injury population. Although Hayden in 2005 did a review of 61 randomized controlled trials just for back pain, and that's, again, a small improvement, but really none of these specific to pain related to post-traumatic injury in the spinal cord population. And I can tell you that pain following spinal cord injury population is very significant. So really specific to spinal cord injury, Meta in the Archives of Physical Medicine and Rehab in 2016 did a systematic review of the pharmacologic treatments for spinal cord injury and pain afterwards, and it was an update from a prior study in 2010. And at that time, there were 35 total studies and 7 new studies since 2010. And their conclusions actually were that gabapentin and pregabalin for neuropathic pain were very well studied, and that there was strong evidence for neuropathic pain. The other antidepressants may help those that are depressed, although there's, again, question about how much depression is active in pain. For spasticity, specifically baclofen, whether orally or baclofen pump and Botox were effective, but additional studies were needed to look at combination therapy and a subtype analysis. So in conclusion, though, the key point is that classifying the type of pain is probably the most important thing. Giving opioids for neuropathic pain is not likely to be helpful. Using pregabalin or gabapentin for musculoskeletal pain, not likely to be helpful, but may be helpful much more for neuropathic pain. Unfortunately, there's limited, well-studied options for adequate pain relief in chronic pain, and specifically in the spinal cord injury population. Geriatrics and spinal cord injury together provide other wrinkles, and it's important to ensure a balance between the risks and benefits when giving medications. Thank you.
Thank you very much, Professor William. Now we'll move for the second talk. It's controversies in stem cells treatment. and the proliferation of stem cells clinics by Professor Eric, he's spinal surgeon in University of Texas. Please, Professor Eric.
Thank you. Again, thanks Sammy and the crew for inviting us to participate. Really a wonderful conference. So I'm going to talk about controversies in stem cell treatments and really about the proliferation of clinics that are happening, especially in the States. Nothing to disclose relative to this presentation. And so I've given this talk a couple times, and so if you've seen the movie Forrest Gump, I'm going to talk about that. So the question I'm asking is, are stem cells still considered the future of medicine, or are they the Forrest Gump of all treatments? This is a scene from the movie where he's sitting on the park bench and says to the lady next to him, my mom used to say that life is like a box of chocolates. You never know what you're going to get. Just like stem cells. You never know what you're going to get. Or the US presidential election. I won't go into politics anymore. So where are we today? Stem cells have shown promise for years, but scientists are really just still learning how they work. There are lots of anecdotes, but not a lot of real evidence outside of blood disorders. Some documented success in cardiac repair, eye disease, etc. And in 2016, the National Institutes of Health funded almost $1.5 billion in stem cell research. So one of the big questions is really, what are stem cells in terms of where they're affecting healthcare? So are stem cells a disruptive technology leading to new breakthroughs? There's a book by Neil Riordan, who runs a set of stem cell clinics in Costa Rica and Panama. And he's got very good anecdotes. They claim that they have treated 116 spinal cord injury patients with about 70% of the time some kind of improvement. So this is the case of a 29-year-old male who suffered a crush fracture from a fall. He had stem cell therapy and very intensive physical therapy, and he went from an ASIA score of A to an ASIA score of D. So this is an anecdote. I'd like to see way more evidence than just one individual case. So this Stem Cell Institute, again, they claim to have treated 116 patients with about 70% of the cases restoring some function, 50% due to the stem cells, according to them, and 50% due to physical therapy. In the US, about 1.4 million North Americans suffer affected by traumatic spinal cord injuries. Most are over 30. The lifetime cost for care is high, 1.1 to 4.6 million per patient. And if you look at clinicaltrials.gov, there are about 230,000 clinical trials in 193 countries, but only about a little over under 30 were spine related. There are about 12,000 new cases of spinal cord injury in the US per annum, and there are about 300,000 patients living with neurological consequences of those problems. So stem cells have been hindered a bit. So in August of 2001 to March 2009, George Bush, who was our president, there was a US federal ban on new lines of embryonic stem cell research, and it could be argued that this set back research about a decade. There were many negative ramifications to the actions that they took. It made research harder because you needed two types of funding. The collaboration and sharing of knowledge between scientists was hindered. American researchers who were at the forefront of stem cell initiatives were no longer able to offer as big a contribution. There were only 21 existing lines of embryonic stem cells, but they were not genetically or ethnically diverse, meaning that specific disease processes could no longer be studied. And in terms of therapeutic application, all 21 lines were of decidedly poor utility, as they were cultured under inferior conditions by today's standards. In 2008, Yamanaka discovered a way to induce pluripotent stem cells. He got a Nobel Prize for that in Japan. Our own Mike Hagenes, who is a past president of NAS, just recently discovered nerve-derived adult pluripotent stem cells, and he's still working on the research there. But this can help speed the research. And there's a question, though, about whether or not these adult-induced pluripotent stem cells have the same qualities as embryonic stem cells. This is from Barack Obama when he reversed the ban. He said, medical miracles do not happen simply by accident. They result from painstaking and costly research and from a government willing to support that work. So Hemocort is one of the few blood products approved by the FDA to treat blood disease. The FDA would like to regulate stem cells, but it's difficult for them to do so. The FDA really regulates interstate commerce in the United States. They work on labeling for interstate commerce. The problem that they have is that if it's autologous use of a stem cell, it comes from an individual and goes back into that individual, and it's not changed in the process, they cannot regulate it. So they would like to regulate it, but they cannot. There's this legal loophole. It's called exemption for a 361 product. So if somebody meets these criteria, if the product meets these criteria, minimally manipulated, intended only for homologous use, not combined with another article, and then either have no systemic or metabolic effect or are for all autologous use, then the FDA cannot regulate it. They have just released some new guidelines for stem cell regulation, but there's going to be a legal fight on this front within the community. Interestingly, the pharmaceutical industry is very concerned about stem cells because they can't sell you your own stem cells. So behind the scenes, we think that the pharmaceutical companies are putting pressure on the FDA to get more aggressive on regulations. But the FDA is also out there to help stimulate innovation. So the FDA is in a tight spot. At the state level, most states and their medical boards have taken no action regarding stem cell clinics. However, they are getting more attention. In California and Texas, for example, they've each passed laws on stem cells, but they're completely different. California is focusing more on consumer protection. Texas is more about the right of businesses and patients to take risks. And by the way, Texas is the only state in the United States that is a state by treaty and not by annexation. So they still think of themselves as a separate country sometimes. So stem cell tourism is really the focus of the rest of this talk. There was a myth in the States that you had to go to China, India, Mexico, or the Caribbean to get stem cell treatments. But the reality is that there are hundreds of companies now in the United States. There are almost 600 clinics across the United States. There's 113 in California, 104 in Florida, 71 in Texas, but that's probably gone up. And what are they looking for? The factors. Well, they're looking for population density, whether there's a use of alternative treatments common in that area, if they have an aging population, lax regulations, and of course, money. The problem is that stem cell tourism it's being compared to the herbal supplement field. You know, over the last decade, sales of vitamins and minerals, et cetera, have grown tremendously. It's now valued at a $107 billion market, with 28% of that in the United States, and that growth is expected to continue. So the stem cell industry is being compared to the herbal supplement field. What's going on in the Trump administration? Well, they haven't done anything on stem cells. Mike Pence, the vice president, is anti-embryonic stem cell use. Luckily, they have not taken a position on stem cells. They've kind of left it alone. But here's what's going on. This is a group called AdMarket. You can take an online course, buy the equipment, and bingo, you are in the regenerative business field. You don't even need to be a physician to do so. The clinics are out there. They're offering 30 different types of treatments for 30 different types of conditions, facelifts, breast augmentation, joint injuries, soft tissue, degenerative conditions, you name it. So this is the marketed stem cell types, adipose-derived, bone marrow, amniotic, blood, etc. And if you look at the types of conditions that they're treating, the first two are orthopedic and pain, and then the third one is sports. So this is a map of where the clinics are. Again, Southern California and Florida is where they're most prevalent. But you've got to be very careful. This Cell Surgical Network, this is from their website. I looked it up. On their website, this is in the fine print. It says, Cell Surgical Network does not claim that any of these applications are approved by the FDA or are even effective. We do not claim that these treatments will work for any listed condition. Patients look at the glossy ads and everything, and many of them are desperate, so they don't read the fine print. This is also on one of their websites, same one, the book called The Sealing Hell, with a message from Pope Benedict. So they're even invoking religion in this. So is this the future? You're going to drive up to a stem box and ask for a double shot. Lawsuits have started in the United States. 3 people with macular degeneration in Sunrise, Florida were blinded by ocular injections. Each paid over $5,000 for their procedures. The doctors don't know what caused the blindness, and they all settled out of court. What was discovered was that it was bogus marketing. Patients thought they were part of a government-sanctioned clinical trial run by the National Institutes of Health because the ocular trial was listed on the clinicaltrials.gov website. It's a little-known fact, but you can list whatever you want on the clinicaltrials.gov. There is no regulation on it. It's not reviewed. So study sponsors can list trials on the website without the sanction of the NIH. It is not policed. So this is unscrupulous clinics listing their trials as a marketing gimmick. In Southern California, StemGenics Corporation got into some trouble. Civil lawsuits from 3 patients who paid more than $15,000 for treatments for lupus, diabetes, and other ailments. But StemGenics on their website claimed 100% customer satisfaction. But the treatments had no effect. StemGenics settled out of court. They no longer claim 100% satisfaction. This was their satisfaction rating. 90% exceeded my expectation, 10% met my expectations. I looked on their website yesterday. This is gone. So stem cell clinic origins, I traced it back in the Ukraine. They've been in business for almost 30 years. They claim that they're the first. I'm not sure they are. They claim that they have treated thousands of conditions for a number of years. And then it grew into Eastern Europe, Western Europe, Asia, Central and South America, and of course North America. In every country that I've visited, I always look to see if there's if I go onto the web, if I can find a local stem cell clinic. There were 4 listed in Saudi Arabia, but I'm not sure that they're actually the same kind of thing. They might be university-based. So what's ahead? Well, the global market for stem cells has been estimated in the U.S. at $12 billion. That was in 2014. It's projected to reach $26.6 billion by 2020, which is a very healthy return rate, 13.7%. We'd all like to get that on our money. So is this the future? You're going to go to a stem cell depot for a part for your body? And the big problem is we don't want this to cast a negative light on legitimate stem cell research. Legitimate stem cell research is typically done in university settings. Rick Fessler in Chicago, a friend of mine, he's doing myelin recoating and having some success with that. Wellington Su, who's chairman of our NAS Biologics Committee, Jeff Wong, who was here yesterday. You heard Michael Failings yesterday as well. There's lots of people doing excellent work with stem cells, and there's more to come. So the bottom line is caveat emptor, buyer beware. Due to the proliferation of stem cell clinics, it's got the potential to damage the public's faith in stem cell treatments if it's not held in check. Thank you.
Thank you, Dr. Eric. Next will be the final talk in this session. We'll have Professor William Sullivan again, and he's going to talking about rehabilitation of the following spinal cord injury, cutting-edge strategy.
Great. Thank you. So we're going to change gears here a little bit